Hi, everyone. Welcome back to the last session of our retreat. So this is really a panel that I very much am looking forward to. We wanted to make sure to get, if you will, the community voice at this retreat. And so we put together this panel, and you can certainly read who's on it and likely saw it in the agenda. But, you know, we have some county health people, we have some a state health person, we have something regarding, you know, community and government solutions for health information, and then the session is going to be moderated by Sarah Wiehe, co-director of the Indiana CTSI, and remember that she also has a hat of the director of that MONON collaborative that was mentioned this morning. So it all fits together well, and Sarah will lead and moderate this session, and hopefully we'll all learn something about the community voice on the social and structural determinants of health. Sarah?
Thanks, Melanie. Just before the break, there was such a nice segue by Dr. Valentino, I think in the question that you asked, Melanie, that acknowledged the importance of community partnerships and her important work. And I really couldn't agree more. Community partnerships are critically important for our work, particularly as it relates to the social and structural determinants of health and health equity. Because without this grounded insight from our partners, individuals with the lived experience, and the roadmap for both the solutions and sustainability of our collaborative work, we won't get to our goals. And so this community voice panel, I think, will exemplify the importance of community partnerships in our work. And specifically, we would like to highlight some of the awesome work ongoing in this arena by individuals working here in St. Joseph County, as well as statewide, as Melanie mentioned. So I would like to very warmly welcome our distinguished panel and ask each member to introduce themselves, and then we will jump into relatively brief presentations, about 8 minutes each, for each of them to sort of talk a little bit about what they're doing in this space and how they got started. I would ask folks that as questions arise, please enter them into the chat. And after everybody has had a chance to sort of give their brief remarks, then we'll engage in some cross-cutting discussion with the panel members. So be putting your questions in there, and we will circle back with them with some time for question and answers toward the end. So Heidi, do you want to kick off the introductions?
Sure, I'd be happy to. Thanks for having me. Sarah, would you like us to do an introduction followed by the 8 minutes, or do you want to go around do introductions first?
I thought we'd do brief introductions first, and then each one can dive in, if that's okay.
Okay, well, wonderful. So I'm Heidi Beidinger, and I'm the director of the Master of Science and Global Health program here at the University of Notre Dame. And I also have the privilege of serving as the CHeP liaison for Notre Dame to CTSI. So have been involved in that work now for about 5 years. Additionally, as many of us do here at Notre Dame, wear multiple hats, and I am also the president of the Board of Health for the St. Joseph County Health Department. Thanks.
Great, thank you. Dr. Mark Fox.
Hi, thanks also for the opportunity to be here this afternoon. I'm Mark Fox. I also wear a couple hats. My day job is as the Associate Dean and Regional Campus Director for the IU School of Medicine in South Bend. And my clinical work is with the County Health Department, where I'm the Deputy Health Officer, focused primarily on community health improvement initiatives. My background is training clinically in both internal medicine and pediatrics with a fellowship in preventive cardiology. So I spent a lot of my professional life focused on cardiovascular risk reduction, but also have worked in community health settings addressing unmet healthcare needs and trying to think about how social and structural determinants of health impact health access and outcomes.
Wonderful. Waldo?
Hello, everybody. Waldo Mikels-Carrasco. I am the Director for Community and Governmental Solutions at the Indiana Health Information Exchange. Prior to that, I was with the Michiana Health Information Exchange, right there or right here in downtown South Bend. And prior to that, I was actually had one of Heidi's jobs, and I was the CHeP liaison to CTSI for Notre Dame, where I actually worked for another of our presenters today, Nitesh Chawla, in the Interdisciplinary Center for Network Science and Applications. It's been a while, doesn't roll off the tongue. And the Institute for Latino Studies.
Wonderful. Dr. Merritt?
Hi, everyone. My name is Breanca Merritt. I am the Chief Health Equity and ADA Officer for the Indiana Family and Social Services Administration, also known as FSSA. In that role, I'm responsible for leading our Office of Healthy Opportunities, addressing social risk factors and social determinants of health, as well as integrating racial and social equity related efforts and policies throughout the agency to ensure racially and socially equitable outcomes for the people that we serve. Immediately prior to this position, I served as founding director for the Center for Research on Inclusion and Social Policy at IUPUI. And also as a clinical assistant professor at IUPUI in the School of Public and Environmental Affairs. I currently still have an affiliation with the university as an adjunct in the Africana Studies program in liberal arts. So I'm wearing fewer hats than I used to, but excited to be here. Thanks for the invitation.
Wonderful. Thank you for the introductions, and I'll pass it back over to Heidi. Thank you.
Awesome. So, so we were given two questions. One is, how did we get started in this work? And the other is, what are we doing in this space of social and structural determinants of health? So the work that I'm doing in this space is that I'm focused on lead poisoning prevention. That's where my research has now taken me in the last 4 years. And just as a quick refresher, lead poisoning is a stubborn and devastating public health issue that we've been working on in this country for nearly 100 years at various degrees of persistence. But lead is also, and more importantly, is a racial and environmental justice issue because there are communities of color and poverty that are disproportionately affected by lead poisoning. And if you were on earlier today, Dr. Miranda had her maps that were describing how lead poisoning disproportionately affects communities of color and race. So how did I get started in this work? Well, the alarm bells were sounded off in December of 2016 when there was a headline in the South Bend Tribune paper that said that South Bend neighborhood has a higher rate of lead poisoning than Flint. And that if you got deeper into the article, it actually said that the lead poisoning rates that were happening here in South Bend were actually 6 times the rate of lead poisoning that was occurring in Flint. So clearly sounding off the alarm bells, and what was our community going to be doing? So at the time, I was a member of the Board of Health, and the health officer at that time, which preceded Dr. Box, came to me and said, we literally have 1.5 people who are focused on this topic and have so few resources. Is there something that Notre Dame could do and step into this space? So recognizing that something needed to be done because the effects are so devastating, I took that call to action back to campus and started networking with colleagues on campus. And while that could be a long story, the amazing thing here is at Notre Dame is that a few phone calls and a few meetings later, suddenly within 3-4 days, we had amassed a group of 12 people who were interested in talking about this topic and figuring out what we could do. We quickly, of course, realized that we needed to be organized, but get connected to the community immediately. Something about my background is that I've been trained in community-based engaged or community-based participatory research. And so I carry those principles with me all the time. So knowing full well that it is not the university who's going to try to solve this problem, but rather how do we partner with the community to solve this difficult problem. So very quickly, we got connected to the Near Northwest Neighborhood Association, which is a CBDG, a community-based development group. And they were situated right in that neighborhood where this was happening. And fortunately for us, they were very much open to partnering and learning more about what was going on with lead poisoning. This led to a series of, we had town hall meetings, we had a meeting with the mayor, with the health officer, we had numerous meetings with community members, parents, and let me tell you, when we invited parents to those meetings, those were emotional meetings. There was not a dry eye. These were parents who were describing the devastating effects that were happening to them and their family. And the fact that they felt so hopeless and that there was nowhere for them to turn. They felt like they couldn't sell their home. They couldn't leave the problem behind because who was going to buy a home that had lead in it? So all of that is the motivation and the passion in which I think the people who came together to create what we call our community coalition is called the Lead Affinity Group. We came together with that passion and desire to do something about the problem that was happening here in our community. So the Lead Affinity Group, we meet monthly for an hour and a half, and we've been doing so for 4 years now. So we're pretty focused and determined group of people. And in the beginning, we came together so that we could learn and support each other about what was going on. But now we've more clearly delineated what our focus is, and that is we do advocacy, we increase awareness, and we encourage policy change. So we engage leaders who are in this space to have these conversations, to bring about a sense of urgency and put these topics at the top of people's agendas. So next, after having gotten that established, we then established a team here at Notre Dame, and we call ourselves the Notre Dame Lead Innovation Team. And we are an interdisciplinary team. Myself, I have been trained as a public health expert and epidemiologist. We have an analytic chemist, a physicist, and a GIS specialist. And bringing those community-based principles with me all the time. The other commitment that I now have to this kind of work is ensuring that we have an interdisciplinary team working on these kinds of problems, because it is the different ways in which we approach things and the different lenses through which we look that we're able to come up with more creative solutions. So the Lead Innovation Team, we started out actually with a really simple question, and that is, what is the gap in services of families who've had a child who tested positive for lead? So who is not being helped by the current system? So at that time, again, the health officer had told us we had 1.5 people who were working on this issue, lots more children who were lead poisoned not being served. So our team, the Lead Innovation Team, wanted to step into that space to say, so for the kids who are not receiving services, is there something that we can do? And this is for a lot longer story, and I would love to have coffee or wine with anybody who wants to have more of this conversation. But after receiving an internal seed grant for $7,000, and now receiving several more grants over the last 3 years, our Lead Innovation Team has developed a lead screening kit. That's a low-cost DIY way for families to independently screen their home for lead hotspots. So the idea is that a family can identify a lead hazard in their home before poisoning occurs. Because I don't know if people are aware, but in our country, unfortunately, the paradigm that we use in our country to find environmental lead hazards is that we wait for a child to be poisoned first. We wait for a positive blood test to come back. And then that's when our system engages and begins to help the family. So our team, the Lead Innovation Team, wanted to flip that paradigm. How do we give tools to moms and dads to be able to do that prevention work before children are exposed or poisoned? So right now, our team, having had this success, we've documented this success, we have validated the kit and published that work. We have now been awarded a HUD grant, a Housing and Urban Development grant, where we are going to be scaling up the distribution of this kit. So not only scaling it here in St. Joseph County, but this also now includes Marion County as well as Vermilion and Vigo County. So to date, we have tested 600 homes in St. Joseph County and have learned a great deal about where lead exists in our community and who's being affected by it. And again, happy to discuss more of those details if you're interested. And then finally, in addition to doing this work on our kit, the lead poisoning issue has huge tentacles, and so it speaks directly to the social and structural determinants of health, because you can't just be focused on this one thing. It's got these tentacles that go everywhere, and you have to follow that and respond to it. And so with our work with the Lead Affinity Group, for instance, we've been able to advocate for new leadership at the mayor's, at the city level. We've been able to advocate for increased funding in our community. And as such, at this time, we actually have over $6 million new dollars in our community devoted to this topic. Now we'll pat ourselves on the back for all of 10 seconds because we still need to be, we still need to do a better job reaching the families who need this the most. And then finally, just a word about policy, because that was mentioned in an earlier, I think it was Nitesh or Dr. Hudson, who was talking about the importance of taking translational research into policy, and that has happened here in South Bend and St. Joseph County. Two important pieces I'll mention is that the city adopted an ordinance called the Rental Safety Verification Programs. It's not perfect yet, but we have launched ourselves in the direction that we want to create safe and healthy housing before people move into it. And then secondly, our South Bend Community School Corporation has adopted a policy that makes lead testing of children part of the pre-K entrance requirements. So now when children go pre-K, they're coming into school and they have to do those entrance requirements, and they have a list of immunizations and so forth. Now lead testing is part of that for the South Bend schools. So so this work, I didn't know this was going to happen, when we started on this 4 years ago, but on this journey, we've been engaged in community-based research, in the translational research, the community partnership, and translating that into policy and to something that will be useful for families. So happy to talk more. Thanks, Sarah.
Thank you, Heidi. That was inspirational kickoff to the panel. I'm excited for the discussion. But first, we're going to pass it off to Mark and take it away.
Great, thank you. Kind of like Heidi, I didn't necessarily set out to do community health research. I failed to say in my introduction that my PhD is in theological ethics, and I really thought I would spend most of my professional life contemplating how many angels can dance on the head of a pin, or actually most of my work was on transplant ethics and policy. My dissertation in the first 15 years of my work was focused on that. But my fellowship was in preventive cardiology, and increasingly I became concerned that the ultimate success in transplantation was dependent on our ability to reduce the need for it. And so through my fellowship, did my M.P.H, which I wish I had done at the outset, because it really has been such a formative education for how I view the world now, I think. But continued my work in transplantation, and then happened into a position where I was clinically running a network of community health clinical initiatives with a variety of community partners, different school districts and faith-based organizations and community mental health centers, and was the Associate Dean for Research Development in my previous position. And those were viewed as two really distinct and separate endeavors, and increasingly they merged as our research focused on issues related to health access and outcomes and social and structural determinants, and how we can leverage health information technology and just rethink how we engage in clinical care to address some of those issues. So have done much less work focused on transplantation, but because of my background in preventive cardiology, was tasked with developing a cardiovascular risk reduction program in the area of Tulsa County in Oklahoma that was the scene of the largest race riot in the United States 100 years ago. And our research showed that there was a 14-year difference in life expectancy across a 7-mile span from where the medical school was in suburbia in South Tulsa and this area in North Tulsa that was the scene of the race riot. That community had the highest rates of cardiovascular disease and cardiovascular mortality in a state that's among, consistently among the highest in cardiovascular disease and mortality. So we developed a cardiovascular risk reduction program, and it became clear very early on that the challenge was not in having providers who were skilled in ordering labs and assessing labs and taking care of patients once they were in the exam room. And so we partnered with the health department and with community organizations and churches and the barbershops and the beauty salons, really trying to find individuals who were marginalized from the healthcare system, often because of lack of insurance, but additionally for a host of other reasons why they weren't accessing care. So it became much less about the clinical care that we delivered and much more about the outreach and the barriers that those patients were encountering. At about the same time, I was also tasked with working with an adolescent emergency shelter just to meet their regulatory requirements for health screenings on admission. And I didn't have any excess providers to do that work. So I ended up going one night a week to examine kids in the shelter just to keep them in regulatory compliance. And after about 2 months, I stopped looking for another provider because I found that work so compelling. I loved the kids. I had great respect for the agency. It made me aspire to be a better parent because most of what I saw there was the consequence of failed parenting. So I would go home and hug my daughters a little tighter every night. But recognize that the challenge wasn't for the kids in the adolescent emergency shelter, who by and large all had Medicaid and had access to care. They didn't have good navigation, but there was a whole population of 1,500 kids living on the streets or couch surfing or kind of in the shadows who had no insurance and no access to care. We developed a street outreach clinic to serve that population. And really a lot of my community health research focus grew out of that work because we went through a variety of iterations to really understand what the needs were, what the challenges were, what the barriers were, understanding what the impact of adverse childhood experiences are on, how we access healthcare, what kinds of healthcare settings are acceptable or preferable for that population. And that led to a lot of my work related to adverse childhood experiences and impact on trust in the medical profession. So as I came to South Bend, I've tried to translate some of that work, continuing to work with the Youth Service Bureau in St. Joseph County, looking at unmet healthcare needs, the impact of adverse childhood experiences on health-related quality of life, and also extending that, looking at cancer patients and cancer survivors and the impact of adverse childhood experiences on their access to healthcare. Really to think about what trauma-informed care looks like for both access to screening and treatment. And then in my work with the health department, have worked closely with Heidi around childhood lead poisoning prevention, but also trying to expand and think about how all these issues relate to immunization access and birth equity and a whole host of other issues. And as Heidi kind of alluded, lead poisoning doesn't occur in a vacuum. There's a host of other health-related social needs that are often paired with that. And so trying to expand the focus of the local health department as we address those needs for this population. And then the last thing I'll say before I hand it off is in that work also have gotten to partner with Waldo, who I think will speak next, and trying to leverage the repository of data that exists in the health information exchange to think about how we cast the net, not only to think about patients impacted by lead, but also kind of the properties to which they have been attributed, and thinking about different ways to triangulate the data to ensure that all the kids in our community who need lead testing have had access to that and are able to access that. So it's been exciting to find partners like that, and with the school, as Heidi said, on policy issues, to try to come at the challenges from a variety of different angles. Thank you.
All I can say is, wow, you have a heart of gold. It's filling my soul hearing you all speak. Thank you. Waldo?
So my charge here was to answer the same questions, but also kind of touch on a couple of other points about what's happened locally. So my background is in applied medical anthropology, and I was at the Notre Dame in the Institute for Latino Studies, working on kind of the social conditions of Latinos. And that immediately, percolated up the question of access to healthcare, access to insurance, and health disparities. And once that got my attention, it was all downhill from there. I've been focused on health disparities and social determinants for the last 15 years. That took me to work with Notre, and eventually the interest and the work on getting more and better data around social determinants, especially at the person level, and as the information would work together, actually drew me away from working at the university and towards a health information exchange. Because once I learned that there was a place that had, decades worth of data for millions of people, that was hook, line, and sinker right there. I wanted to work there. So I've been working in health information exchange since 2014. And one of the big things about working at MHIN, or the Michiana Health Information Network, rather, sorry, acronyms, was the beginning of the Health Improvement Alliance of St. Joseph County. In my role at MHIN, I had the benefit and the privilege of being able to do outreach to operationalize the data that was in, or that exists within the Health Information Exchange, to the betterment of the community. So with that view towards community benefit, I had the opportunity to interact with a lot of groups which the IHIE had never reached out to in the region. And one of the things that kind of, serendipitously, never mind. And anything, one of the things that occurred during that same period was that the St. Joseph County Health Department was undergoing a National Public Health Performance Standards Assessment through the CDC that was being moderated by Purdue Health Partners. At that point in 2011, they brought together a number of community organizational stakeholders to have a discussion around what the system in St. Joe County for public health and healthcare was. And it really unearthed a number of things through that conversation. One was there was a lack of availability of community data. Two, the interorganizational communication or trust amongst organizations was lacking. And that there also was a lack of community partnerships. Organizations kind of took on their own initiatives without consideration or discussion with other ones. So those three things kind of distilled through that process and really captivated the members of the stakeholder group. And they continued meeting after the assessment process had ended. And in 2013, the Alliance itself was formed as a loose organization of member organizations in St. Joe County, working a number of health-related fields. Today, the Alliance is comprised of close to 100 cross-sector organizations across the region, not just in St. Joe County. But these include healthcare, and by healthcare, I mean medical, which is health systems, federally qualified health centers, provider groups. We have oral health, community health. We have community health workers, community paramedics, prenatal and postpartum home visitors. And we have public health also prominently represented. We have social and human services organizations like United Way, food pantries and food reclamation projects. We have housing, transportation, interpersonal violence programs represented, economic assistance, and others that come in contact with us. We have mental and behavioral health organizations, including community mental health centers and addiction providers represented. Municipal government, city and county officials come and go through our meetings and gatherings. Payers, Medicaid, managed care organizations. Academic researchers have been with us since the very beginning, particularly Notre Dame, but we've also had the benefit of Purdue, IU School of Medicine in Mark's representation certainly, and others has been there. IUSB, which is the Indiana University at South Bend, for those of you in other parts of the state, and Ivy Tech, amongst other researchers that have come and gone over time. We generally have about 100 attendees at our regular Alliance meetings every month. And we have a website that we try to kind of provision with information. Currently right now, there's a lot of COVID information being shared, but to kind of fulfill that need to help organizations coordinate to reduce the duplication of programming that maybe is unnecessary, reduce the duplication of services and try to fill gaps, and then also provide a broader sense of communication across organizations. We have a data and kind of analytics group that tries to provide information at the county level or the local level that is sometimes hard for provider organizations or even researchers sometimes to find. And if researchers create kind of novel data that corresponds to our area, we try to include that so it's kind of disseminated at the local level where people need it or want it. A little bit more about what MHIN was doing and has been doing as a member of the Health Improvement Alliance. It was a founding member of that process of the original stakeholder group. Its nonprofit board has been, since its inception, focused on operationalizing the health information exchanges, the organization's data, to improve outcomes in the region. And it's always had a special focus on health disparities and social determinants of health. Beginning in 2020, MHIN and the Indiana Health Information Exchange, which was a separate HIE in the state, agreed to consolidate into one statewide HIE. Small problem, a global pandemic occurred, and everything turned to collaboration with the state as the chief focus. So the consolidation got a little overtaken by the pandemic, but that really gives a chance to show the importance and the capacity that an HIE has in dealing with massive events like the COVID-19 epidemic, and we've been able to support the state on a variety of data and reporting initiatives. And this is important because as HIEs, IHIE and MHIN represent some of the largest and oldest HIEs in the country, with close to or about 20 years of longitudinal data. And that represents 92% of Indiana's population. And as some of you may know, Indiana only has about 6.7 million people. We have 15 million individual records. So we have people from out of state and nearby states that may have gotten care in Indiana. IHIE, the Indiana Health Information Exchange, which is now the consolidated organization, developed a social determinants of health strategy upon consolidation that supports the Indiana Network of Patient Care, which is our repository, supports the members of that repository, the hospital systems and providers who provide information and use information from there, as well as state partner agencies like the Department of Health or the Family and Social Services Administration. They support those agencies in health information, of course, but also with social needs efforts to improve health of Hoosiers from a social or comprehensive or person-centered perspective. Part of that plan is to understand the appropriate role of an HIE in collecting and utilizing social needs data. And we're trying to deploy a collaborative social determinant strategy that supports member organizations and state partner agencies, both at their individual levels, if they're trying to work on individual programs or programs that they're funded for, but also at a comprehensive level where we're trying to work across organizations and convene and coordinate and promote collaboration across our organizations, and not just in healthcare, but across sectors as well. Many of our HIEs colleagues across the country or other organizations in other states have taken the approach of using a screening and referral approach to social information using platforms like Aunt Bertha or NowPow or Unite Us. And that's great, that's important. And Indiana has a long history with Indiana 211 and now with FSSA's Indiana Community Connect. We decided to take a different approach and actually kind of look at the person and the administrative needs of that person. Rather than just providing or collecting referral information, try to focus on use cases that look at the social needs and develop pragmatic multi-sector data sharing projects. The idea is to make limited but critical administrative and clinical data available to social services and healthcare providers to successfully transition individuals across case and or care management and to remove the barriers to collaborative person-centered decision-making. The integrations that we can point to most recently over the last year that we began working on were integrations with the state Department of Corrections and Medicaid managed care payer organizations, where we're trying to provide information to Medicaid of, we're sharing information with the state prisons, we're getting information on when these individuals are coming out of the prison system and trying to get them connected to medical homes or make sure that they're connected to Medicaid and that their prescriptions and conditions have a care treatment plan that's being communicated across those organizations. We're also doing EMS data integration with the Department of Homeland Security to try to make that information available within the hospital record and to make information from the patient record available to EMS companies to improve their quality, the quality control and their decision-making in the field. We partnered with the Indiana CTSI Monon Collaborative as a community-based partner. And we're focusing on advancing the coordination and collaboration of social services and resources to achieve better outcomes, both economic and health, but focused on vulnerable populations. Currently, we're developing an HMIS or Homeless Management Information Systems data sharing pilot with the Coalition for Homeless Intervention and Prevention in Indianapolis for the Marion County area. And we're partnering with CHeP, that organization, FSSA, and the Medicaid managed care organizations. And this pilot represents a framework for future expansion into additional use cases and scaling geography. So as soon as we prove this in the Marion County region, our hope is to work with IHCDA or the Indiana Housing and Community Development Authority, which manages the HMIS system for the rest of the state, to scale this statewide, but then also look at other domains as well of social determinants. So the idea would be to expand this, and we currently have work groups around this to just involve reentry, food security, and additional special populations such as HIV infected individuals. Nationally, IHIE chairs the Social Determinants of Health Committee for the Strategic Health Information Exchange Collaborative, or CHeP, as it's called, and in their aim to improve the uniform collection of and operationalization. I'm so tired of social determinant of health data in HIEs across the country. So our hope is that this information can be collected uniformly and that it can be used to provide population level information, not just for clinical outcomes or health, health outcomes, but the social information that contextualizes what is affecting that health and what are the conditions, the social conditions that those communities are living under. Many of our HIEs, including IHIE, are part of the Office of the National Coordinator funded STAR HIE program, which is focused on improving COVID-19 vaccination data or connecting immunization information systems to health information exchanges. And this is being done in order to improve vaccination rates and outreach to historically underserved, minority, rural, and hard to reach communities, particularly those historically and disproportionately affected by social and structural determinants of health.
Waldo, there is so much to share. I'm sorry. I knew this would be difficult, particularly for all the things that you're doing. It is impressive, not just the activities and the approach, but actually the systems level change that you're a part of. Thank you. But I want to make sure we hear from Breanca as well, and then and give her full time, and then we'll take some time to answer questions. So I just wanted to remind folks to start sprinkling in questions as you have them for the various presenters, or a cross-cutting question, that would be great. Breanca, I'm going to hand it over to you. Thank you.
Yes, thanks, Sarah. I'll try to be as succinct as possible. I guess answering the first part that others have discussed about why I got into this work. I've always been very passionate about policy change and what that entails. And so my path was a little winding in getting to that point. For me, it was always about creating more equitable policy design, and I did not think that could be accomplished without community engagement. However, those were neither equity nor community engagement were terms that I knew existed at the time. And so I started off working in public policy and politics, and for me that was great in terms of kind of, statistical measurement and really thinking about what is happening, but I never got the context of how it was happening, and really kind of was discouraged from pursuing opportunities to get more background and learn about context, because I thought, well, we could just ask some people why XYZ policy is affecting people this way. So I ended up actually in health promotion and public health, and really building my community engagement chops in particular ways. For me, that involved working with and doing program design and program evaluation with different rural Native American tribes throughout Oklahoma, and driving several hours throughout the week to engage with different communities and understand kind of how programs could be implemented in ways that were equitable and effective. And so for me, collaboratively, that kind of helped me kind of refine and hone kind of the intersection between government and politics, as well as health outcomes. And I think being in public health prior to the health and all policies shift, there was really kind of this idea, and I think it still exists, where it's like policy is this big nebulous thing. I think we think about it at a very federal level and not so much about what we can do locally to make change, especially through research and especially through community engaged research. So while I was at IUPUI, I think we had several opportunities to really meaningfully make those connections between community engagement, research, and policy change. One example that I like to bring up is about thinking about local policy change and what, as researchers, people can do to kind of hone those skills. We did a lot of work around eviction way before kind of this eviction, and certainly before like this COVID environment around eviction took place, so several years ago. And so for us, and our research team, it was about really listening to what people were saying and stakeholders who were involved in housing. And for us, we learned just a ton, not just about the eviction process, but in how that was affecting different populations with an eye, and going into that with an eye toward racial equity in particular. And so it enabled us to not just identify trends and experiences and statistical trends and experiences, but really being able to kind of corroborate that with policy decisions and what needed to be changed based on them sharing their experiences with us and us working with them in an ongoing fashion. And so we produced some reports that really focused on not just eviction, but the inequity around eviction. And we had some folks in Marion County. Our eviction process is handled at the township level, and we have multiple townships within Marion County and Indianapolis. But different township judges and other personnel and leaders would frequently reference our report and specifically hold it up in meetings and say, we've got to do something about this. And they will frequently reference our report, work back with us, and kind of get our feedback about what policy change looks like at a local level from an equity perspective. Another example is thinking about what policy change looks like at a nonprofit level. One example that our team did, and this was a very time-intensive experience as well, was working with a community center in Indianapolis that was doing some work around crime prevention and wanting to know how they could engage youth to not pursue crime long-term. And so we spent really an entire year pretty much camped out in that neighborhood. And one of the biggest findings that we had was about the need to address ongoing and latent trauma among a lot of the kids who were going to that center. So they immediately were able to get funds to invest in counselors and other types of supports to make sure that those kids ended up getting the support that they needed long term. And so they've been able to leverage that work for several years now as a means of not just getting support for mental health care, but all types of other supports for the youth who attend. And so I think those are examples of how policy change happens. It's very local, very attainable through a lot of research from a community engagement perspective. Changing to FSSA and the work that we do, and Waldo kind of alluded to some of it, as it speaks to social and structural determinants. We created the Office of Healthy Opportunities a couple of years ago, which focuses specifically on addressing social determinants of health. We like to think of them specifically as social risk factors rather than determinants, because these are things that put you at greater risk but may not always determine your outcomes, but obviously they're very strongly related to them. And so the creation of that office was actually kind of a first, not just in Indiana, but nationally as well. And so we've received a lot of acclaim for that work because the intent was always to integrate and meaningfully link social service provision as a major facilitator of not just health and social services policy, but things that directly and indirectly affect individuals and families' health. And so through that office, we've had several opportunities to really address the health needs of Hoosiers from a social determinants perspective. One, the WISE Indiana partnership, which CTSI is a part of, which really aims to leverage kind of research partnerships and skills like community engagement and others to really speak to issues of social policy, health outcomes, et cetera, to better link the work that we're doing at the state to researchers and experts who can help us leverage and dig deeper into that, into those trends. Another effort that we've had is the Hoosier Health and Wellbeing Atlas. We actually developed, and I was around kind of when they were developing this a few years ago, a survey tool that is provided to anyone receiving services from FSSA. So if you're receiving Medicaid, you're signing up for Medicaid, you're signing up for SNAP benefits, you would take this 10-item survey, and it's purely about social determinants. And so it helps us understand not just at the individual level what someone's needs might be, but collectively being able to identify trends across the entire state at the county level to understand not just trends and social determinants, but also racial ethnic differences and other different demographics to inform our decision-making about how we can better serve those populations and engage with them. We also have recently housed Indiana 211, which of course is the number you call when you need help from social services. And so that's now within our agency. And we're also developing an effort called Indiana Community Connect, which is a way to kind of take 211 into a structure that enables partners to better access and understand what gaps exist and how to better connect clients and service recipients. And so collectively, we've done a lot of work to date. In my role, I'm responsible, as I alluded to earlier, in creating more anti-racist and socially equitable policy design throughout the agency. And so a lot of that is, a big chunk is community engagement, and not just creating kind of these ad hoc groups when we're applying for a grant or when a certain issue comes up, but having that ongoing relationship, not just with key stakeholders, but also with Hoosiers, and again, folks who are receiving services, so that we can kind of continuously understand, where our gaps are, how we can better support folks, and particularly doing that from a lens of racial equity, but also considering things like disabilities, gender, and other factors, rural location, so that again, we can more equitably serve Hoosiers across the state. So with that, I'll turn it back over to you, Sarah.
Thank you so much, Breanca. It is really awesome work that you and the team are doing at Indiana FSSA, and thank you for sharing that, as well as the, I don't know if it's appropriate to say small p politics or small p policy, but like you do small p politics, but that's sort of how I think of it. And I think it is, as you mentioned, so important. So Melanie put in a first question, and again, I would encourage folks to put in questions if you have it for the panel. But her question is, if you had, and we'll go in reverse order here. So Breanca, we'll start with you. If you had a magic wand and could have one additional resource or support mechanism for your work, what would it be?
Oh boy. So I would kind of cheat and say like 1.5 things. I'm glad we're speaking to this group, because I think with the work that we're doing related to racial equity, I think our team definitely needs research support specifically in racial equity and community engagement. And so being able to have kind of an ongoing evaluative process for every single thing that we're doing in our agency is a crucial piece of how we identify gaps and develop policy design and programs that can be more equitable. So I know this is a research group here. So anyone who's really interested in pursuing those types of social policy and health questions as they relate to equity is definitely something that we would need on an ongoing fashion.
That's great. And that's a call to action if I if I heard one, so that's great. Waldo.
So I would not ask for myself or for my industry. Healthcare has benefited from a lot of federal investment and a lot of technology being worked on, but the social service sector, who really kind of deals with the social part of the social needs, is totally, disjointed and siloed. The technology is old and not, even when not old, not well connected. There are not a lot of standards. There's conflicting policies for, information sharing, privacy, and confidentiality. The whole design is almost as if they want to stop from collaborating, coordinating services. And that's what people desperately need. They don't want to have to tell their story 1,000 times, produce documents 1,000 times. So if I could have one resource, it would be to have the resources to help the social service sector better coordinate that journey or that path for folks trying to seek services, and be able to coordinate that information better with other things like health or governmental administration information.
Mm-hmm. Very insightful. Thank you. Mark?
As an administrator, my response is usually there's nothing that a little time and money can't solve. So I think that's part of it. I would love to see more creative policy approaches to appropriately align incentives, especially among both healthcare providers and social service agencies who get it, if you will. And particularly, I think what I would focus on is around, I think there's a lot of talk about being trauma informed and providing trauma informed care, but I'd really like to see our healthcare non-system convert to a system that truly is responsive to that.
Good.
So with one run-on sentence, I gave you one answer, but it's a very large magic wand there.
Well, Melanie did say magic wand, so I think that's fair. Heidi?
So this is such a tough one. If I had the one thing to wave the magic wand, I would say that the call to action is for anybody who is connected to the healthcare system to ask their administrator if they have policies and procedures to get children under 7 tested at 12 and 24 months, blood tested for lead at 12 and 24 months. So if everybody on this call, because we all have friends who are in healthcare, reach out and find out, do we have procedures and protocols in place that ensure that children are being tested at 12 and 24 months? That's what I would want.
Wonderful. That's actually a good segue to a question that I had, which is how can others get involved? Maybe involved more systemically, in addition to, Heidi, I think what you outlined, which is a call to action at an individual, level. How would you, however you want to ask it, how could other folks on this call get involved in what you're doing, or more generally as part of like the social and structural determinants of health needs that we have in the state? Go ahead, Heidi. Yeah,
okay.
Go ahead. Yep.
Yeah, so how others can get involved. So so I would argue that just about anybody on this call can be connected to this work of lead poisoning prevention, right? So, you've got the healthcare industry, but I'm also thinking of people who are in the field of contracting and home repair. Those are folks that we need in this space as well. Another big space is we need help with marketing and campaigning and reaching the tough to reach communities. We're not doing a good job with that. And the research is not there to support us in terms of what direction that we need to go. So I know we need help there. So, and then on a personal level, if you live in a home that's pre-1978 and you want to get your house tested, I saw somebody Maria put in the chat that a link to the kit. You can request a kit from us and we can help you to get your home screened. So there are, as I said, we have to take an interdisciplinary approach to this really stubborn and persistent public health problem. So everybody can be involved. Just reach out to us.
Thanks. Mark, how can folks get involved?
Yeah, I think, really finding what either your research interest or your passion project is. And, I think the CHeP representatives at different institutions can help connect you with the right community partners or other researchers. I think there is no shortage of opportunity to answer questions that researchers pose. I know health departments all over the state would beg for help in answering some of the tough questions. So, but I think the CHeP mechanism is the great entry point to serve as the swizzle stick and get people connected, depending on what their question or their passion is.
Well, thank you for the plug. I appreciate that. Waldo?
So I would agree with Mark, and I would say that even if you don't have a formulated question, connecting with organizations like the St. Joe County Health Improvement Alliance or other alliances around the state, or state groups, there is a ton of organizations out there like that are looking at community scale complexity, social complexity, where it isn't. And I think, one of the other panelists mentioned this as well, right? It isn't just food insecurity or housing security. Socially complex people are socially complex. They have a lot of things happening at the same time. They're just dealing maybe with one thing at a time, but communities have to take all of that into consideration. Whereas maybe an organization just focused on food is just looking at food. So I would say, reach out and certainly connect with communities. And then CHeP is, I think, a fantastic conduit to help kind of connect that research to those issues in those communities.
Thanks, Waldo. Breanca?
Yeah, I mean, I would say that if you are more of a traditional researcher, that some of this work is a heart game as well as a head game. And so if you have the opportunity to kind of move outside of what your departmental or disciplinary culture is around community engagement, especially as it relates to policy, to do that as often as you can. And I think to Waldo's point, working with local organizations to help kind of move your perspective from kind of how does this benefit me to how can I benefit someone else through my research, or how is my research more relevant to different populations based on what I'm hearing on the ground. I think any opportunities you can in your, I put quote unquote free time, because I mean, who really has that, but to the extent possible that you can kind of join legislative hearings or you know, join different community meetings. Like those are going to be places I think where you benefit, but ultimately the work can benefit community members and policymakers by developing and modifying work that's relevant to those folks.
Great. Well, I know it's at time, so I'm going to pass things right back over to Melanie. I don't think I could have summarized it any better than what the speakers have already said. So thank you all. A big heartfelt thank you to our panelists. Really, really great insights and a call to action. So couldn't have asked for more. Melanie.
Thank you, Sarah, for your leadership and support and for moderating this panel.